Well, it's a real pleasure to be here. This is good for our culture that we have a Latino conference that is running on time, and and you can thanks Maria for that. And it seems like it's a very good conference. We have very good speakers, with my exception. And about the interim dean, most people have been happy except my wife. Three things I would like to cover, and we want to have some time for questions and answers. We'll talk about the prevalence of obesity, and we have some slides how that disproportionately have an impact on Latinos. We'll talk about the science. There's not a lot that we need to know about the science of obesity, but some ideas, and a lot of slides and about policy and things that we could do, and things that we're not allowed to do. Go back to this. So this interesting, I have the scale there because it seems to be what defines obesity, and it's unfortunate because it's not a super accurate instrument to assess adiposity. But that's what we have, and that creates actually more confusion when we're trying to talk about being healthy and high levels of fitness. It all goes down to how much do you weigh, and you need to exercise. So when we try to translate our scientific discoveries into policy, we start with this ladder, and some of you have seen this. But we start with surveillance, and it's to define if there's a problem. If you were probably lived around the 40s, 50s, and 60s, smoking was not a problem. Everybody did it, and so we measured it, and it was not until later that we started realizing that smoking was a problem, and then we identified that it was a problem for lung cancer, and now we went from here to here. It took a lot of years for moving from it is a risk factor for lung cancer and other diseases and heart disease to start evaluating how can we prevent people from smoking, how can we make people quit smoking. And we still have a large percent of the population who smokes, who knows that it's bad for them, but they can't quit for whatever reason. And then we start implementing things. We raise taxes, we take it away from vending machines, we prevent the kids from having access to tobacco, etc. And we start working with ideas that could work to prevent smoking. Obesity is somewhat similar. Who cares if people are overweight, obese? That's not my problem. They can do whatever they want, eat, don't exercise, etc. That's their problem. But then we start realizing that it was connected to many, many, many chronic diseases. And we have data that it's not just that are chronic diseases, it's very expensive. These diseases that are associated with obesity are very expensive. And then they're starting earlier in life, and when people get sick earlier in life, then it starts to having an impact with business. And when you affect business, then all the gloves are off. We don't want to affect the economy. So then we start identifying what are the risk factors. So we have two things here: obesity as an outcome, what causes obesity, and obesity as an exposure, what happens once you have obesity. So when we're looking at the science and the policy, you have to be very specific about what is it that you want to do. If you want to reduce diabetes, obesity is a risk factor for diabetes, so maybe we just need to concentrate on lowering diabetes and don't worry about obesity. If you want to reduce obesity, now the risk factor for obesity are different. Might not be related to diabetes, but we're trying to avoid obesity. And that's very, it's a good distinction, because we're going to talk about preventing obesity, not preventing heart disease or diabetes. Unfortunately, when you build insurance, you don't build somebody for this person is physically inactive. That's not a code that you can get paid back. You get a code like diabetes, heart disease, you get paid for treating those diseases, but not for treating lifestyles per se. So we evaluate what works, and this is, I think, where we are. We are at that stage where we're trying all kind of things things that you say, that's really, that's way out there, but we have to try things. Some things might work, some things might not work. And we do these randomized controlled trials, and we do very controlled experiments. And once we find something that works, then we try to implement it across the population. Sometimes we go here without having the evidence, because some things make a lot of sense. Some things we have to test them, and we at that stage where researchers like myself and others are applying for funding to look at obesity prevention strategies. I'm not sure how many of you followed the legislature, where we had a bill that the vending machines in public buildings would provide healthy snacks. It makes sense. I'm not sure if from the other side, we're asking our public employees to lose weight and to live a healthy lifestyle, yet the environment that we provide them is with vending machines and not so many healthy snacks. We were able to move the vending machines with the sodas out of the high schools, and now we have these kids from high school going to college, and they come back and say, oh, they are the vending machines again. So it is a tough battle. It is a tough battle, and that's where getting from science to policy becomes somewhat not frustrating, but it's a long-term engagement. Obesity. So you probably are also familiar with the fact that we talk about overweight and obesity, and we use it interchangeably. Well, they're not the same. In fact, I'm not sure if you were able. A couple of months ago, we had a meta-analysis where we found that actually overweight was not a risk factor for all-cause mortality. And it's somewhat confusing because then people get mixed messages. So one of the problems that I see is that we are using, again, the scale to identify obesity. Obesity, I would say, if you have to define it, it would be excess adipose tissue. Too much adipose tissue in your body. And that then, it varies when you're a child. It varies among adults. There's a difference between adipose tissue that is okay and healthy and nice to look at, between different groups. And then we have this very rudimentary formula that we're using, body mass index. And it has a high reliability in terms of correlation. People have high adipose tissue, have high body mass index. People who are obese have a high body mass index, but not everybody has a high body mass index is overweight or obese. And there are people who are not overweight and obese who have high adipose tissue. So, yet we have that all over the place. We look at diabetes, you take a fasting glucose measurement in the morning, and if it's high, that doesn't diagnose you with diabetes. That tells you that you need to have a couple of other tests to give you a diagnosis with diabetes. We do the same thing with blood pressure. You take blood pressure, comes high, you need to have some other tests. We do the same thing with body mass index. It creates problems because the people who are against policies to prevent obesity, they accuse us that we're using this body mass index to classify people on obesity, and that is not a reliable instrument. We have that all over the place. We have, and actually it's probably better in terms of the number of true positives that you get with body mass index and high adipose tissue than you get with other instruments. This is, you probably have seen this if you have a child. This is the growth charts where you put the weight and the height, and then Johnny is in the 20th percentile or 15 or 75 percentile. And, you know, the pediatrician would say, well, you know, it's normal, it's growing on the curve. One of the things we have found is as the bones, as you're growing, will grow to support the weight that you put on. In fact, one of the best, and I shouldn't say this in a large crowd, one of the best protective factor against osteoporosis is obesity. People who are overweight have very strong bones because they have to carry extra weight, and that's how the bones stay strong. They will die from other reasons, but not from osteoporosis. So the same thing happened with kids, which is if they have a lot of body weight, their bones will grow, and it will show that they are growing in a chart that it's somewhat healthy. What happened is as Johnny becomes 16, 17, the bone growth will stop, but the body weight will stay. And he might not be as tall as you thought he was going to be, because this doesn't keep track of you when you're 21 and 30 years old, but the other part of the weight stays. So we have to be very, very careful when we take into account the growth charge. So where are we? So if you think about, this is data from when we started assessing body weight in children, 1970s. We didn't have a national data sets where we can say who's overweight, who's obese. So in 1970s, the National Health and Nutrition Examination Survey, and then that year it was called the National Health Survey, they took a sample of average kids, or national representative sample of children. They classified their BMI from 0 percentile to 100 percentile, and at the 95th percentile, okay, says from here up, these are going to be obese kids, because we have to start somewhere. So what we have now is actually a statistical definition of obesity, not so much a biological definition, but it is what it is. So about 5% of the kids, by definition, would have been obese, and subsequently, in 1976, it stayed about the same. In 1988 to 1994, this is Haynes 3, we saw an increase in obesity. And this, from going from here to here, we almost triple. From here to here, about double. And this is kids 2 to 5 years old, 6 to 11, 12 to 19. And we were concerned. And we actually talked to anybody who could listen. We talked to the American Public Health Association. We didn't get one reception at that stage. Now we do. But there were very few organizations that were taking us seriously. It was now in the year 2000, and more recently, there's some recent data, that this is the same kids. There's no reason, everything being equal, this line would say obesity has stayed at 5%. But we have about a 3-4 time increases in obesity from 1971 to 2000. For people who think that it's genetic, the genetic pool doesn't change that fast. This doesn't happen because of genes. This is environmental exposures. And environmental exposure could be defined in many ways. These are girls, so it's the same pattern. So we have quadruple the prevalence of obesity in less than 30 years. And this is statistical differences, especially among African American and Mexican American kids. If you look at the prevalence of obesity between 1994-2000, Haynes 3 to Haynes 2000, among non-Hispanic white, this is a P of 0.35, but it is significant among African American, and it is among Mexican American kids, both for boys and girls. That raised the question that we have a health disparities here, because we all probably the same kids, same age, same years of that we're looking at the trend, but it's more significant among one group and less so among another group. It's not all bad news. There's some good news toward the end. The prevalence of obesity as the kids get older also goes up, and it goes up higher among Hispanic boys and among African American boys. There's this low prevalence of obesity among African American boys. We're not sure exactly if it's a statistical aberration. One hypothesis is the low birth weight, and they are catching up, and they catch up, and then they actually are, prevalence of obesity grows, it's bigger than among whites. If you look at girls, we have a similar trend that obesity is much bigger among blacks and Hispanic kids than it is among white kids. If you look at potential risk factors for obesity, we published this paper in 2001, and what we were showing here was that the kids who watch a lot of TV have disproportionately higher prevalence of obesity than kids that do not watch that much TV. We also found that the percent of kids who watch 4 or more hours TV is greater among African American kids and Hispanic kids. And this is outdated data, and this is TV watching, didn't take into account the games, that the video games that the kids are involved now. And even in that, the findings are quite controversial. It seems to be that it's the TV watching that is more associated with obesity than the games for some reason. And I could see, the kids when they're playing games, they're pretty, their heart rate is up. They're not like vegetating when you watch TV. They're like sleeping with their eyes open. So we had an editorial from that paper that says, well, we didn't show that TV watching causes obesity. What we showed was that obese kids like to watch more TV. A valid point. So the next step we did was let's look at the numbers of hours of they watch TV and the prevalence of obesity, because another causal factor is dose response. So if that's the case, those who watch more TV should be more overweight and those that watch less. And this is probably a linear relationship for boys and girls. The more TV you watch, the higher the prevalence of obesity. And the next thing we wanted to look at, because the TV industry is very powerful. We had interviews from newspapers and the radio, but no one from the TV asked us to be interviewed. So we look at what was this, the question that the kids were, how many hours TV did you watch yesterday? And then in another test, they asked what you ate the day before. Totally separate studies in terms of when they're in the NHANES, they get blood pressure, they measure cholesterol, they do all kind of things. So they're totally unrelated question. So this is the number of calories that they ate for the kids who watch 1 hour of TV. And this is the number of calories for the kids who watch 5 or more hours of TV. These are girls, these are boys. Boy ate more than girls. And actually there's less variability for girls. We did a trend line, and then we calculate the difference between those who watch 1 hour, those who watch 5 hours. About from here to here, it's about 150 calories. It's not a lot. If you think about 150 calories a day, not a big deal. Now, if you multiply 150 calories, I don't know how many people are nutritionists, dietitians here. It's about 3,500 calories equal to 1 pound of fat. So if you multiply 150 calories times 365 days a year, and you divide by 3,500 calories, that's equivalent to about 15 to 20 pounds of extra weight a year. And then when you look at the weight of kids who watch 5 or more hours TV versus those that watch 1 hour, it's about what you get. So it's quite interesting that it's not that you just watch TV, it's just that you're also eating more calories as you're watching TV. So it's a rather complex problem that we have. It has to do with the environment. It has to do what happened at preschool, what happened in the healthcare organization. Actually, an interesting paper that came out in New England Journal about the Oregon experiment. And those who were randomized into health insurance actually had similar physical health profile than those that did not have health insurance. Which actually, from a public health perspective, it means that healthcare is not the cure to all of our problems. Our problems have a lot of social determinants, not so much having access. I'm surprised that they were not sicker by having health insurance. But anyways, they're good people too. The healthcare organizations, the schools, the faith organizations, communities, worksite, we all have to be in it together. It's not going to work in isolation. If mom and dad wants to give you healthy food, but if they go to the supermarket or wherever they go, it's not there, there's not much we can do. If you want to eat healthy at workplace and you want to go to the vending machine and all you find is junk food, there's not much you can do. If you're a PhD student starting at 3 o'clock in the morning and you get up and you go out down the hall to eat something and all you find is junk food, that's what you're going to buy. So we need to change the environment wherever we are to make it easy. Kids, especially kids, they don't know that much to make a decision that is good for them. And if you think about the science of obesity, it's not that hard. We eat too much and we exercise too little. I mean, that's the bottom line, you know. And I was driving here and I was thinking about this anthropological experiment of the automobile and how we can get here, go there, go everywhere. And that's not that, I mean, we just came up with this idea in the last 100 years. But it has a tremendous impact in our ability to burn calories. It does amplify our ability to do things. We're more productive. So we need to think about, if we do that, then we have to be able to allow people to be active in other ways. And that means that the work site, the school, everybody has to come in place to be able to put more energy expenditure in what we do. We also, this is from a good source, USA Today. It is the amount of money we spend in fast food. So by far, we spend a lot more in fast food than any of the other countries, developed countries in Europe and other places. So when we talk about policies, it just puts people really on edge. It's just very scary when you say, we need some policies, because it means the government is going to run your life. And the government is going to decide what you eat. What's interesting is that has been decided. That what we eat, we don't have that much of a choice. You go to the supermarket, 80% of the products already have some kind of sugar in them. Meat that you think shouldn't have sugar in it has been inserted in it. Because, we like sweet stuff. And if you put a little bit of sweet here, you will buy more. If you put sodium in the food, it's a flavor enhancer, so you eat more of it. If you have a restaurant and you don't put sodium in it, people are not going to come, and you lose business. So their best interest is to have a profitable business, not your health, but some of them are. So if you've seen this, we have increase the size, you pay the same. It's a good deal. It's a good deal. The story about Twinkies, they're not dead, by the way. Somebody else bought them, and there will be Twinkies for a long time. But there are other Twinkies look-alike out there, okay? And I bring this issue because who is going to mess with Little Debbie? What do you have against Little Debbie? She's a little girl, But we have that story. We've been through this before. Remember this guy? What do you have against Joe Camel? He's just a little cartoon. But that's how we get to the kids, And I don't know too much about Little Debbie, but it is how we condition our thinking about this is what we need to do. It says stay in and play, and that's not what my mom told me. It's get out, and if you stay in, you're not playing, by the way. You're cleaning, you're helping, you're doing something in the house, and it was a great incentive to get out. But that's what our kids do. They stay in and they play. A side effect of this stay in and play is vitamin D, but I'm not here to talk about vitamin D. I just got a grant rejected for that. But anyways, it's a critical factor because now we have to take supplements. It's like we can't lower diabetes or obesity, so let's just treat the disease and not worry about the root cause of the problem. So there are market forces out there. I'm not sure I'm sure you know who she is. I have no idea who he is. No, it's not Obama. So Disney actually has a new policy that they're not going to advertise junk food in kids programming because they really care about you, right? Because they really care about the kids. I don't know if they do. But actually, they do have family entertainment is one of their core values. But actually, it was market forces. If you are a parent and Nickelodeon is advertising junk food and Disney is not, which channel are you going to let your kids watch? So this is, and it takes some powerful market forces. Their favorability acceptance rate is much higher than the president. Here's a slide looking at the difference in boys and girls. And if you look at that slide, you can tell me what's wrong with that slide. And some of you have seen this. So as boys get older, their percent participation in physical activity goes up. Okay? And that goes, actually, this is part of the other paper I was showing you with the boys eat more. And that makes sense. They are more active. They eat more calories. Girls, on the other hand, as they get older, the percent of girls who are engaged in vigorous physical activity 5 or more days a week goes down. And this actually works for black kids and Hispanic kids. So we do have an epidemic of inactivity in our hands with our girls. And it does have, this is a paper we submitted September 6, 2001, and then September 11 came, and you know what happened. We sent, so this is a good journal, by the way, American Journal of Medicine. Had we known what was going to happen in September 11, we would have sent it to the Journal of the American Medical Association. But what we were saying here is if we recruit all the kids that are 17 to 20 years to join the armed forces, how many of them would be rejected because they were too heavy for their weight? And about 45% would not, especially women, would not be able to join the Army, the Navy, and each one of them have different criteria for many. I learned a lot by writing this paper with Nolte. And I guess for the Navy, you can't be more than 7 feet tall or 6 feet because you can't fit through the doors of the submarines, etc. So they have some very specific criteria. But what ended up happening is about 15% of our youth, or 17 to 20, would not be able to join the armed forces. So this is not a health issue anymore. And then September 11 came, and one of us went to the Capitol to testify about the fact that if you have a draft, 15% off the bat of our youth would not be able to join because they're just too heavy. So it became a national security, and I think that's when it became more important. If you think about how inactive we are, so this is, some of you have seen these slides, but it's quite impressive. This is 70 to 79-year-old data in the terms of people who do not exercise at all during leisure time, okay? So these are his Mexican Americans. So this is the prevalence of inactivity among Mexican American women. And if you follow that up here, that is higher than any 20 to 29-year-old white. So inactivity is very high. Here is the prevalence on Hispanic women. It's about 42% at 20 to 29. That's higher than the prevalence for whites. And if you look at men, the same thing. So this is the prevalence for Mexican American men. It's higher than it is for whites, 70 to 79 years old. Meaning inactivity is very high among adults. This is 20 years and older than it is among those 70 to 79. The thing is, you don't turn 20 and you say, today I'm going to be inactive. These prevalence are higher way before. These are kids who have been inactive way before, and we measure when they're 20, and that's what we have. But this means that it's a behavior that is very endemic in our community. And the environment is not helping either. And we have engineered physical activity out of our life. And you can't complain, especially with the carpenter who uses a nail gun, because he's building a house. He's building 3 houses at the same time he used to build 1 house. So there's productivity in how we engineer things. And if it is your house, you want him to use a nail gun. But that's activity, energy expenditure we're taking out of our occupation. So it's very complex. We have child weight, we have behaviors that are around us, we have parenting, skills, and we have community and demographic factors. All of them contribute to obesity. And it's rather easy. It's just a matter of us getting together and connecting the dots, okay? And if you're a student looking for a project, just get into one of these boxes and say, okay, let's see what's the role of access to healthcare. Oh, it's connected to this and that and that. And it makes it very hard for us to develop policy, because policymakers, when they see something like that, they laugh. Yeah, exactly. That's exactly what happened. So we need to learn about how to design healthy communities, and that's a critical factor. Our communities, we have designed it around the automobile, and the designers, the planners, they make sure that right before you get to your suburb and there's that traffic light, you're going to find McDonald's and Jack in the Box and all this and Taco Bell, and that's right before you enter into that suburb, and it's 5:30 and the kids are hungry in the back and you're tired too. What are you going to do? You're going to go through that. You don't even have to get off the car, you know. Before you park in your house, the kids have eaten. And you can just go and watch TV and have a happy evening. So we took those boxes and we try to make it more systematized. And this is one way where we're trying to look at obesity prevention and the prevalence of obesity and the factors that are impacting. So it's too much food, there's lack of exercise, and then we look at the aspects that have an impact on that, starting from school, family, starting for occupation, etc., and how those are contributing to the prevalence of obesity. And these are ways that we can actually start looking at what is it that policy-wise that we can do to prevent obesity. And these are the good news. There have been some successes. We had a trend that it was up. In fact, Robert Wood Johnson Foundation made a pledge of, I think it was $500 million to curb the rate of obesity. And I remember one of the first funding project was in Arkansas, where they told the schools that they have to measure height and weight for their kids. I brought that idea in Oregon, and my tenure in Oregon almost was cut short. The teachers don't want to deal with that. The education system says that's not our problem. You know, I'm not measuring weight, and that's too hard. That's very difficult to measure height and weight. It's not that hard. It's not that hard. The other part is you have to tell the parents, here's Johnny's BMI. And they didn't want to do that either. There's the D, there's the F, and now BMI is 95. What's going on? So they didn't want to do that, part of because, you know, we need to find a solution for that. Now the kids don't have health insurance, etc. But Arkansas did it, and there was a lot of criticism. But it was the first state that saw a curve in the rate of obesity among children. If you don't measure it, you don't know it, and if you don't know it, you don't have to do anything about it, which is why we have to measure data on Latinos, on blacks, on Asian, because if we don't measure it, we will never know, we'll never have to do anything about it. So it's critical that the better data we have, the more granular data we have, then the more we can see what is it that needs to be done. So in this case, we see that it's this Colorado, which for many, many years has been the state that has the lowest prevalence of adult obesity. Yet it's now the state that has seen the largest percent growth. It's still low, but it's going up. This is Colorado. This is Virginia. This state that you see, there are a couple of states where there's no way to go up or down, I guess, because they were probably among the highest. But that's progress, you know. That's progress. It's Tennessee, and this is Maryland. And that's about instituting very proactive policies. If you go to the states, you see that they have tried to make efforts to bring back healthy foods at lunch school and increase physical education in the classroom. So you have to be progressive about some of these things. Oregon is also in good company. It's one of the states that have the lowest prevalence of childhood obesity, and that's good. There's a variety of things that you can say why that's the case. It could be measurement error, but it could be. No, we are actually, Oregon is one of the most active states too. It's in the top 10 of physical activity among adults. So the American Diabetes Association provided some recommendations about obesity prevention, and this was specific about culture and obesity. It says that the prevention should take into account everything in terms of the families, communities, and cultures. The primary care provider should routinely discuss obesity risk with children and families. If you don't have health insurance, too bad. But if you have access to a primary care provider, that should be discussed. This discussion should vary in frequency based on your background, which makes sense, and this is actually an important component of cultural competence. Another aspect, very, very important one, is breastfeeding and prevention of gestational diabetes. Very critical in our community because the rates of gestational diabetes among Latinos mothers, it's higher than among whites. And breastfeeding is good for preventing obesity. Different theories. Part of that is the child learns to regulate food intake on his own instead of having a bottle, and when he's done, there's a bottle, and he doesn't have a choice to stop the bottle from coming in, whereas breastfeeding, he can control some of that. I'm not an expert in breastfeeding. So this is also good news. Among Latino women, the rate of breastfeeding is higher than it is among whites, blacks, and other groups. Actually, there's some interesting data within Hispanic subgroups. The rate of breastfeeding among Puerto Rican women, it's much lower than it is from whites, about the same as it is for African American. But breastfeeding among Mexican American women is much higher. Another recommendation is for healthcare providers to play an active role advocating. Yeah, right, somebody said that. So healthcare people should advocate for policies to foster a healthy environment for all children, including restriction of youth-targeted television advertising, promotion of regular physical activity and healthy choice in schools, and provision of safe place for children to play. This is an example of what happened when the kids are watching TV. They're exposed to advertising of junk food, and this is a sunny day. There's a dog outside wanting to play. It's, you know, but yet they're here. Actually, the cat is eating the food, somebody here. So this is, I should speed up here. So this is from a study that was done about kids who have a TV in their bedroom. And I didn't realize that was the case. Among Latino, Hispanic kids, more than 50% have a TV in their room, and among African American and Hispanic kids. So I was testing this with my daughter, and she said, "Dad, we're Hispanic. I don't have a TV in my room." I said, "Well, that's the good news for you, but the bad news is Daddy has a college degree, and that means that the more educated the parents, the less likely is that they're going to have a TV in their room." And it is something that we need to be concerned about because it does have implications for obesity. This is the amount of time that the kids reported that they spend doing media. And if they tell you they're doing homework, they're not, okay? Because that's what they say, but this is what they're doing. So I think I'm going forward here. So we have some people out there who are rocking the boat and implementing policy. This is in New York, where it says children who are 12 months, this is about daycare, shouldn't have the TV be in the babysitter, so no more than 60 minutes. 3 years and older, they should participate in 30 minutes of structured physical activity or 60 minutes of total physical activity. Video games, visual recording are not permitted for children under 2 years of age. And these are policies that are put out there for people who are dropping their kids for childcare. Having playgrounds for kids to be able to participate in physical activity. I wish I had something that fancy. But anyways, we climbed trees and we threw rocks at the neighbor's house. That worked too. Yeah, and then we ran. There you go. Yeah. This is PE in the classrooms, and you can see how it just goes down as the kids get older, and it have a disproportionate impact among Latino kids. PE that is in each grade. So again, as the kids get older, there's less PE, and that correlates with girls having less physical activity. We also know that in low-income communities, the schools do not have the resources for having that PE teacher, etc. I don't know how many of you walk to school. I did walk to school, but we don't let the kids go to school anymore walking. The environment is not designed for us to walk to school. So even if you want to, and you know, that's the other thing. When I went to school, there was no parking for the students. The parking was for the teachers. You know, you're a student, you walk. But that's not the case nowadays. We build huge high schools. They don't fit in our communities. They have to fit whatever the farmer is willing to sell the land. And then that's where we put the high school, and you can't walk where it is. So that's another part of how do we design the environment so we can actually have more physical activity. This is a great program, Safe Route to School. Oregon is in the forefront of, I don't know how many of you have seen this bicycle on the road. Well, that's an example of an intervention of Safe Routes to School. I'm going to try to move fast here so we have a chance to, family intervention, especially for the Latino community, very important, very important. I wish I had more time to show you a couple of slides. We did an intervention in Baltimore. We put a sign that says, instead of taking the escalator, take the stairs. And it worked. When we had the sign, people took the stairs. When we took the sign, people did not. When we analyzed the data by race, it works among white, but it didn't work among blacks. That was really confounding because if overall it did work. So we went back and did the same day, the same sign, and we put a picture of a black lady behind, and it worked for both, for whites and blacks. And it was not a language issue, it's about you're speaking to me now. In El Paso, a similar intervention was done. The same sign, one had a picture of a family, for the health of your family, take the stairs, and then the other sign, just take the stairs for your health. And it didn't work for Hispanics. When the family sign was, the Hispanics took the stairs. So you need to attract people to where they actually said, you know, that's something that speaks to me. And these family interventions are very critical, especially among the Latino community. And I'm sorry I extended, but I think we have 10 minutes or so for a question. This body composition in school children, I think it's something that we should think about being able to implement in Oregon. We need to include health and physical education from K through 12. I know the brain is a terrible thing to lose, but so is 95% of the rest of the body. We need this multidisciplinary partnerships to make it happen. It's not just mom and dad who have to. It has to be how we plan the community, how we build the schools, how the SIC industry interacts with us to make us healthier, how to include arts and music. You know, if you dance salsa and merengue for half an hour, I'm not going to ask you to exercise, okay? But you will don't call it exercise because those people stop doing it. That's the other part. But, you know, there are ways that we can involve other parts of what we do that increase physical activity and also safety in our neighborhoods. Thank you. I'm sorry I extended. Thank you.
Questions?
You need this?
Hi. Well, my son's 15, and he's played 2 sports so far, and he's a sophomore. And each time we had to pay at least $100 to $300 just to do a sport. And how are the lower income folks supposed to be able to do that? It really makes me angry.
Yeah. I mean, if you think about health disparities and how we have a disproportionate impact on some people, so this is a critical example. And I do want to talk about fluoride. But if you think about, you know, some of the examples that you hear is, well, take Johnny to see the dentist and the dental hygienist, you know, and they will do that. That means you have to have health insurance. 2, you are now using 2 health professionals, not cheap ones, and they have each a secretary and a receptionist. And it gets very expensive to be able to do that. So there are things that we can do that have an impact for everybody and are low cost and can actually make people active. Designing your neighborhood so it's easier for you to walk to school, it's almost a no-brainer. Yeah.
Just add a little bit on here. I'm from the Hillsborough area, and I come from a lower income background, and I actually played sports. And anybody that's on the free and reduced lunch meal plan, there are programs for you to get into like soccer or anything in high school, but it was only in high school. So if there's any policymakers here in the school district, I mean, please, keep that open for the students that are on the free and reduced lunch plans. So, yeah.
Because in the school system, and this is the other issue with the boys and the girls, the competitive sports, the football, the basketball things are after-school programs, and if you can afford it, then you can join them. And if you can't, you have to rely on whatever physical activity you get in PE during the school day. And if they are not offering PE during the school day, then there goes your chance.
You spoke to it a little bit, but I'm just wondering what kind of things you found when looking at why the activity levels of boys go up and the activity levels of girls go down as they get older.
I have 2 girls, so basically I have anecdotal data. But you know, it's interesting that boys, and the parents also have this thought. You know, you have a future playing football. You have a future playing basketball. But the girls don't have a future playing football and basketball. So they have, the kids, the boys, have this mentality that I hate math, I hate science, I'm going to play sports. And they spend 2 hours practicing a free throw, and they get good at it. And I talked to some of these boys, and said, you know, how many NBA basketball teams are out there? So like 30 or so. How many new players they get every year? Oh, they get about 3 new players every year. So 3 times 30, 90 new players. Yeah, I'll give you 100. They get 100 new players. You know how many people graduated from medical school last year? Over 1,000. So what are your chances of you becoming an NBA professional basketball player versus becoming a medical doctor who is going to have a long, successful, rewarding career? But that doesn't sink in. They prefer to do the sports that is going to get them that extra job. So I think the boys are interested, basically because they don't want to do homework, that they'll do a sport that is going to have a future for them, where the girls are more interested in things that will actually really have a future for them.
Thank you. I really like how you are placing all the environmental causes that are causing obesity.
Thank you.
I think one of the most important partnerships has to be with the community in all those levels. In many cases, many researchers, doctors, I mean, all the organizations, you know, with the best intentions are working with the communities or for the communities, but not with the communities. Mm-hmm. And I think that's the key element for any success in any strategy. I'm coming actually from Wisconsin, and that's what we are doing in an obesity family intervention and working with the community, so the community can take the lead and empowering the community to take the lead for that.
That's a very good point. We tend to think that we know what's best for everybody. One way I learned, we talk about crime and safety in the neighborhoods, and we collect crime data, so that's what we work with. That's data, but that is not a good predictor of whether people are going to be outside being active. It's the perception of crime. So crime itself, and I used to live in Howard County in Maryland, and it's a yuppie community, I guess. And then you have Baltimore City. The crime rate in Baltimore City is like 400 a year or so. In Howard County, it's maybe 2 a year. And that year, we went from 2 to 4. And people were scared. You know, people would not go out. You know, crime rate went 100% up. Yet in Baltimore, it's not, that wouldn't stop anybody. 2 extra deaths in homicide would not stop, but it's the perception. If people perceive there's high crime in my neighborhood, I'll stay in, but regardless of how much crime is out there or not. So when you work with a community, you will go in and says, you know, you will not exercise because they're high crime rates. No, I don't exercise because look at the sidewalks, or look at what are the things that are actually important for them. Thank you.
Hello. I wanted to ask you something. I'm kind of new to Oregon. I came from the East Coast. In one of my previous life, I was a professor at a community college. One of the programs we had a dental hygienist program, and we had one for vision. And one of the things I did was I went out to communities and to the agencies that help, people in need. Yeah. They provided services either at no cost or very reduced rate, because the dental hygienists and the students at the Vision Center needed to have certain amount of hours, of actual patient contact. Mm-hmm. So they were able to tap into and provide a lot of services at free charge to a lot of those kids, and adults mm-hmm. that needed the help.
Yeah. No, that's a good point.
You have to have that here.
No, I'm not sure about that project, but imagine this concept where a local medical clinic or hospital decides to pay a PE teacher to provide physical education at the elementary school that are near their hospital. because the school doesn't have money. And they're going to say, you know, we will pay for that PE teacher because we're going to gain from that. These kids are going to be active, and that's going to prevent diseases in the future. Nice concept, but that's not in their job description. I'll be attending a meeting in June. It's called Health in All Policies, which is precisely about that. I mean, how is it that the transportation fellow has to have health in whatever he does? How is it that the guy who's building a house has to take into account health? Because if we think about, we're all interconnected, and the way the system is designed is this, an empty bed in a hospital doesn't make money. But if we turn things around to the point where we're all connected with this, so if it's the school system who is training dental hygienists that could go to a Department of Education and provide some service, it all comes around. Fortunately, that's not exactly how we have developed our standard government agencies. I don't know whether I think we don't have, I'm sure that there's some dental hygienist group that go to the schools, because there's some programs in Oregon that do that. Pacific University does it, yeah. Yeah.
Oh, we got another question over here. There's my physical activity for the day.
Thank you so much. I wondered if with the children, the Hispanic children with the increased TV in the bedroom, did you look at the number of rooms in a house and the number of people, like in terms of crowded? Because that's my experience, is there's fewer rooms per number of people in the household, and so that might be where that's their playroom.
I see, yeah. No, I didn't look at that. I did look one, this is a separate issue, crowdedness and blood pressure. So among whites, the crowder the household, the higher the blood pressure. But among Hispanic, the crowder the place, the lower the blood pressure.
So I believe we have time for one more question. Oh, yes.
This exercise.
I'm curious to know if your research has looked at all at being born by cesarean section as a potential risk factor for obesity.
Oh, no, I haven't. I have two daughters. One was C-section, one was not. Both skinny. But it's a good point. I don't know. It has to do with the breastfeeding. It might be different among C-sections versus women that do not deliver regular. Yeah.
Last questions or comments? Well, let's give Dr. Crespo an applause.
Thank you. Thank you.